We are live.
Very good evening, everyone. And I welcome you all to the first of the series on glaucoma webinars, excellently curated by Dr. Preeti Kamdar and Dr. Sachin Darwadkar. Without taking much time, we'll directly jump into the webinar. Before that, I would like to acknowledge and give a heartfelt thank you to our expert panelists. We have amongst us a legend in ophthalmology in glaucoma, Dr. Devinder Sood. He's no stranger to anybody who's practicing glaucoma in India. He's a past president of the Glaucoma Society of India and a legendary teacher. He is practicing in Delhi. So thank you, Dr. Sood. We have Dr. Kavita, who heads the glaucoma services in Arvind Eye Hospital, Pondicherry. Thank you very much, ma'am, for being here. And we have Dr. Pooja Bhomats, who is a senior glaucoma consultant at Shanti Saroj Nethralaya in Meerut. So we look forward to hearing from you all and advancing our knowledge about glaucoma. Apart from this, we have some excellent speakers. We have three young dynamic speakers, Dr. Sanket Deshmukh, Dr. Sarika Shinde, and Dr. Anil Kalekore. Apart from this, the session will be moderated by Sachin Darwadkar and Dr. Preeti Kamdar, who are both excellent senior practitioners in Mumbai. So without taking any more time, I hand it over to Dr. Preeti and Dr. Sachin to carry the session forwards.
Thank you, Piyush, for the opportunity. It's always a pleasure to curate any glaucoma session. And and I thank Dr. Sood, Dr. Kavita, and Dr. Pooja for accepting our invite and spending time with us. So without any more formalities, let me call Dr. Sarika Shinde. She's going to present a case on a steroid-induced glaucoma. Sarika, can you please share your screen?
Shall I hide it? Is it visible?
No.
We can't see the screen.
Your laptop screen is visible. Now you can share the PPT.
Yeah, but not your presentation.
Doctor, can you please share your PPT? Yes, thanks.
Yeah.
Correct.
Yeah. Is it visible now?
Yeah.
Yes, visible full screen mode.
Now?
It's visible.
Yes.
Let's start. Yeah. Okay.
Go
Good evening, all of you. At the outset, I would like to thank MOS and Dr. Preeti Madam and Dr. Sachin Sir for giving me this opportunity. Steroids are the most ubiquitously used drugs in the medicine and ophthalmology, and making this as a common cause of iatrogenic glaucoma. So ophthalmic steroids are easily available without any prescription over the counter, and often they are self-administered. So most of the patient, they come in an advanced damage because they don't realize the seriousness of its use. So who is the steroid responder? The older definitions are gone now, and the most widely accepted definition says that the IOP increase of more than 10 millimeters of mercury over baseline with some clinical significance is other people with the steroid responders. So coming to the epidemiology or the classification of the steroid responders, after the 4 to 6 weeks of a topical dexamethasone or the betamethasone of mercury are around 61 to 63%. The moderate responders with the IOP elevation of a 6 to 15 are around 33 to 35%, and the higher responders with the IOP elevation of more than 15 millimeters of mercury are 4 to 6%. These are the people whom we have to keep a watch on. So there are the higher percentage of the normal individuals who develop substantially increased IOP if the steroids are administered in a greater frequency with a higher doses and for the longer duration. Coming to the risk factor, along with the age in the children with children less than 10 years, and older folks also are also at the risk of developing the steroid-induced glaucoma. The other risk factors would be previous glaucoma diagnosis, that is POAG, or the first degree relatives with the POAG patients, connective tissue disorders like rheumatoid arthritis or the high myopia, the traumatic angle recession glaucoma, endogenous hypercortisolism, and the diabetes mellitus. So most of the times the patients are asymptomatic, especially the kids when they come in the advanced stage. when the patient develop the
Pooja, we are losing
Your voice is breaking.
Pooja, we are losing your voice. Sarika? Sarika, we are losing
Ma'am,
your voice.
our video is frozen.
Yeah.
Can you hear Sarika though? I can't hear her too.
No, I can't. It's frozen.
Okay, in the meanwhile, I think we can take a
She's
couple.
logged out also. We can come back to Dr. Sanket, please.
Yeah. I think Dr. Preeti, we can in the meanwhile we can tackle a couple of questions on based on what she started with. So we do have these kind of medications over the counter that are available. So let's ask our expert panel. Sarika is back. Sarika, you can start.
Yeah. So
Please share again.
risk of a developing
No,
the
share your
steroid.
screen.
Share your screen. Your screen is not seen.
My screen is not visible.
No,
No.
you're logged out.
Okay. I'll
So
just-
till she logs in, like for all these drugs that are available that can cause a steroid response in the population, according to the experts, what are the commonest offenders that are seen? Dr. Pooja, Dr. Sood sir, and Dr.
Kavita. Dr.
Kavita. Yeah.
I think
Is it
patients who are
visible
used.
now? Sorry.
Yes.
Okay, I think
Full screen.
she's back.
Yeah,
Yeah,
let
I
it
think.
go.
Yeah.
Come on.
So as I said, the risk of developing the steroid response is dependent on the anti-inflammatory potency of the steroid use. The most highly potent steroids are amongst them are the betamethasone, dexamethasone, also the difluprednate. The loteprednol and the newer steroid like rimexolone shows a lesser IOP spike, and it is seen the IOP rise is also seen in a lesser number of people. So there are several routes of administration of the steroids, but the most notorious amongst all is a intraocular route. So the topical steroid, when usually we start, they show the rise in intraocular pressure at the 4 to 6 weeks. When we stop the steroid at the 6 weeks, the IOP should return to the normal within 2 weeks. But if the trabecular changes are reversible, IOP returns to the normal within 2 weeks. And if they are not, if they are irreversible, the IOP rise may persist up to 18 months. There are some subset of people who have an acute rise which is seen within a week or a 10 days of starting the steroids. The another important route the route which we commonly use is the intravitreal steroid in a lot of retinal pathology. The most commonly used steroids amongst them are the triamcinolone acetonide, fluocinolone acetinoid, and the dexamethasone. The risk of the raised IOP most commonly seen is with the fluocinolone acetonide, followed by the triamcinolone, and followed by dexamethasone, which is a biodegradable compound. So whenever you are using the intravitreal steroid in a patients who have a pre-existing or a uncontrolled glaucoma, especially patients with a POAG, known POAG or a POAG suspect, these are the patients whom you have to reconsider because they are the poor candidates for the sustained release implants use. So the patients with the IOP of a more than 21 millimeters of mercury, you have to closely monitor their IOP. Sometimes you need to do the visual field testing and the imaging before starting the intravitreal injection, and after starting the intravitreal injection, the close follow-up with the IOP monitoring is very essential. The patients with a baseline or the good IOP control that is less than 21 millimeters of the mercury, in those you can monitor their IOP regularly. So what if it is necessary, or it is if patients need to continue with the steroid treatment? Whenever the steroids are required, you can, in those cases, you can consider the lower concentration or the weaker steroids. And you have to, wherever there is a mild to moderate rise of the IOP along with some glaucomatous damage, you can start with the anti-glaucoma medications along with the close monitoring of the IOP. So finally, coming to the treatment part. So if the patient has a less than 30 millimeters of a mercury, IOP of a less than 30, the treatment would be similar to the POAG, but you have to stop the steroids and you have to just observe their IOP. If the IOP is a more than 30 with a mild to moderate glaucomatous damage, you need to start the anti-glaucoma medications. In those, you have to reserve the PG analog, especially if the patients, if you are using them in a cases of the uveitis. SLT can buy some time, if especially in the cases with the intravitreal steroids. Although the some patients in the future may require the surgery after 3 to 6 months. The patients whose IOP is more than 20 and who is on a maximal medical treatment and there is an advanced glaucomatous damage, definitely the surgery plays an important role in those. The gold standard is trabeculectomy, or sometimes in some patients, a non-penetrating deep sclerectomy may show the good results. If both of this fails, then you might have to consider for the shunt implantation. If the AGB or the shunt, this surgery also fails, then you might have to, in some advanced cases where there is a poor prognosis, you have to consider cyclodestructive procedures. In a retractable or the patients who have undergone the steroid implants, in those cases, you sometimes you have to consider the pars plana vitrectomy to remove the steroids plus or without a glaucoma procedure. In some mild to moderate cases, the newer surgeries like a micro incisional glaucoma surgeries can play some role, or they can show some benefit. So this is the algorithm we show for the steroid-induced glaucoma treatment. One need to know whenever they are treating the patients in their day-to-day OPD. So the future anti-steroid may come, but they are still under the experimental trial. So I'll be presenting now one case. This was a boy who came to me. This was an 11-year boy who came to me, who was referred to me 1 year back in February 2024. So he came that time with a history of redness and itching in both eyes, which was there for more than 3 years. And when the patient noticed the blurring of vision, he for a 2 to 3 months he went to the nearby ophthalmologist, who then diagnosed with a VKC and advanced glaucoma. And the referring doctor, he had started him on the maximum medical treatment in both eyes, along with the oral acetazolamide and a treatment for the VKC that was in the form of loteprednol and the olopatadine for the 1 month. When I asked, the patient had used some ointment from the medical store for itching and redness for more than 3 years on and off without any medical supervision or the ophthalmologist advice. There was no other significant history. When patient presented to me last year, his best corrected visual acuity was in the right eye 6/9 parts, in the left eye it was 6/12. The presenting intraocular pressure in the right eye was 42 millimeters of mercury, in the left it was 44. On anterior segment examination, the conjunctiva showed the generalized conjunctival congestion with papillae on the palpebral conjunctiva. The pupil in the right eye showed the normal reflex, left eye was a ill sustained with a grade 2 RAPD. The gonioscopy showed the wide opal angles, and the fundus showed the cup to disc ratio around 0.9 with the bipolar neuroretinal rim thinning with the pallor. Blood vessels and the foveal reflex was normal. This was a perimetry with which the patient came, which was done outside, which showed the constricted field in both eyes. This was the OCT which was done outside when he came. So the diagnosis of the both eye VKC with steroid-induced glaucoma was made. And since the patient had a IOP of more than 40 in both eyes with the maximal medical treatment, I decided to undergo go ahead with the trabeculectomy in both eyes, which I first did in the right, followed by the left last year. Post trabeculectomy, since the patient was on already on the low potent steroid, I continued the low potent steroid, but I tapered it fast and I switched to NSAIDs. Also, I added the tacrolimus ointment BID and some lubricants for his VKC. The patient is continuing till the same medicine till date for his allergy. So till 4 months, his IOP intraocular pressure in both eye was well maintained. It was
Sarika, can you summarize? Because we need some time for
14
discussion.
to 16. Then after 4 months, because the patient kept developing the recurrent episodes of VKC, the bleb was vascular and it was flat. And I used to start whenever he used to develop the redness, I used to start the steroid and I used to give the steroid breaks. But his IOP is still persistently high with the maximal medical treatment and with the Dimox with tacrolimus. These are his last week's photos, which are showing the right eye IOP around 20 millimeters of mercury, and the right eye, there was a less congestion. The papillae are not there as such, but there is a lot of congestion. And
Sarika, I think we'll have to conclude because we have to start the discussion.
Yeah.
Okay.
And
The
the left
point
eye,
will-
he again developed the papillae, and these are his gonio and the trap. I have advised now him to repeat the trap in the right eye along with the MMC, and the left eye bleb needling or trabeculectomy. So points to consider in this are the child.
Sarika, I will take it in
Sarika,
discussion.
I think Dr. Preeti, you can start the question part. Sarika, nice case presentation. For the want of time, we'll have to cut
just
it.
one last slide. Just one last slide, sir.
Okay.
Before coming to the discussion, my take-home message would be to the audience that steroids are the double-edged sword. The awareness of the treating physician should be very important. assess the risk factor before starting and check the responsiveness.
We can read it. Sarika,
and
we can
counsel
read
the
it.
patient and
Thank you.
attendant. Okay, thank you.
Okay.
Sarika,
Yeah. So what?
thank you.
Oh yeah. So just as she just finished the case, I think we'll take first few comments from our experts pertinent to this particular case. So we've seen the way she systematically gone through the management. So Dr. Sood sir, Dr. Kavita, and Dr. Pooja, in short, would the management in your hands be the same, or would you slightly change your management in this case?
Dr. Kavita, if you can start, please, the discussion. That when at presentation, would you have started? There is no judgment or anything. Just that if you would have done something different from what Sarika did when the person presented to you.
Yeah, nice presentation, Dr. Sarika. One good thing about this case is like whoever has seen the patient first and started on the medication, it's good that they have measured the intraocular pressure in this age group. And one thing which usually we come across is like though general ophthalmologists, they do treat these VKC patients with steroids. Many a times they do miss recording the intraocular pressure because glaucoma is often considered as a disease of aging. So it's very important like to measure the intraocular pressure like as seen in this case on presentation only the patient had advanced disc damage. And I think definitely yes, when the pressure was 40 plus with this sort of high intraocular pressures, 40 plus, I would have considered a trabeculectomy.
So you agree with what, Sarika? That's wonderful. Not that there was any doubt, Sarika, but it is
No,
just one can have different opinion. Yeah.
No. The
I
point
just
is,
wanted to know.
now that the trabeculectomy has been done, would there have been any other change in the post-operative management of this patient? Dr. Pooja, Dr.
Yeah,
Sood
I
sir,
think
Dr.
she
Kavita?
should have continued the Predford in her standard pattern. But I generally give Predford for at least 2 months post trabeculectomy. She should have continued Predford.
Actually,
I feel like that.
I had continued for a month or 4 weeks, and then I again switched to the loteprednol, and then I switched to the
Yeah,
NSAID.
that must be the reason why your blood must have scarred. So I feel.
And was this a limbus or a fornix-based surgery?
It was fornix-based, sir.
Fornix-based. Okay. Sood sir?
One second. Can Dr. Sarika stop
Sarika, just
sharing?
stop sharing.
Yeah.
If you
I'll
can,
stop
please.
sharing. Yeah. Yes.
Yeah,
Yeah,
Dr. Sood sir, your comments?
Yeah. So when we look at these cases, one is it's a good presentation and not a very difficult case, not a very easy case to handle in a day-to-day practice actually, because the choices are very limited. You have a patient whose pressure is very high, total cupping, and I'm sure there's split fixation. So you have to decompress an eye with a very high pressure. That by itself is a risk. Split fixation by itself is a risk. Then there would be precautions to be taken before, during, and after surgery. We'll focus more on the after surgery part because I think the issue of steroid-induced rise in intraocular pressure post-surgery is going to be a genuine problem to tackle other than the risks of surgery here. I perhaps would have one thing is documentation and discussion with the patient is very important because normally when you do a surgery, patient's assumption is that everything is now going to be fine. So that's something that needs to be explained. Steroids need to be used after surgery to minimize fibrosis and the inflammatory process, but that by itself can lead to a rise in eye pressure. So if you look at all these choices, I think the words which have been used in the presentation are, and please stop me when I exceed my time, dexamethasone, betamethasone, and prednisolone. This is very interesting actually, and loteprednol has been used. Systemically, betamethasone and dexamethasone are the strongest steroids. But when we use them in the form of eye drops, prednisolone becomes the strongest this thing. So I think one change that I would do is I would perhaps use loteprednol acetate as a primary choice and perhaps add a little more non-steroidal anti-inflammatory and carry on with something like combiflam or something orally for a little 3 to 5 weeks to minimize the inflammatory changes that would happen. So this is something, and I would monitor the contralateral eye also because very often we are so focused on the eye after surgery that this is what I would just add to the surgical part.
Okay,
So,
so point well taken. I think all of us agree that the steroids should have been continued for a longer time and would continue for a longer time. Just diverting for just a second, what is the in a fornix-based surgery? I mean, I think Sood sir does more of limbus-based surgeries, if I'm not mistaken. If things have changed of late, I don't know. But most of them who do fornix-based surgeries, what is the protocol of continuing the steroids? Do you stop it or do you continue it for long periods of time? Or is it in the era of medicamentosa and highly inflamed conjunctiva, does a rapid taper help, or we should be continuing them for a longer time?
I think there is no doubt that it has to be continued for longer times. Usually we give up to 90 days or so, 80 to 90 days. Good to maintain them on steroids, to prevent long scarring. As you rightly said, in the era of so many choices of anti-glaucoma medications, the conjunctival cytology is altered. There is a high risk of fibrosis, and hence it's good to maintain it for a long time.
Okay, so I think we are short of time, so just one passing question, if Dr. Preeti permits, is that in all of us, among all the expert panel, what do you think has been for the common audience, what has been the biggest offender of steroid-induced glaucoma in your practice? Just one word answer from everybody.
I think
which
over-the-counter medications.
No,
That is
which
eye drops.
one?
Eye drops
Yeah,
or
no.
systemic.
Assist.
And
So
the efficacy of respiratory steroids to increase eye pressure. The
Sachin,
inhalers.
Yeah, Sachin, can I add something?
Yes, sir.
That
Yes, sir.
very
Please go ahead.
often the patient will not divulge this information actually, that he is on steroid in any form. And I'm bringing this up because classically all of us are in busy practices. We hardly talk to our patients. This is basically a secondary developmental glaucoma. So the word secondary means secondary to something. If you don't talk to the patient, you'll never be able to find out a possible cause. And in a large number of people, 3 to 4 months, if you need to balance this with the optic disc damage, but a large number of them, the pressures can come down if you are a little patient and manage to follow up the patient. But you have to ask. I've had asthmatics who are on inhalers. We ask for a negative history of asthma and document that we asked. 4 or 5 years later, we would come to realize that the patient was on steroids for asthma. They didn't divulge this information even when they were asked, and they're educated patients, but they would
Correct.
never actually divulge. So you have to ask at multiple steps to hear that no from them.
I would echo
Okay.
that. In fact, I would want to share that.
Sir, I would like to add only one more point. As Sir was rightly pointing out, many times we get to see these asthmatics who are presenting with either ocular hypertension or a glaucoma. And one more thing which we have to have in mind is next to prostaglandin analogs, the most commonly preferred anti-glaucoma medication is beta blocker. Recently also we had a patient with very high pressures was put on mis-soft eye drops like BD and the Combigan eye drops, BD both containing timolol, and the patient was using double the dose of timolol with being asthmatic. So that always we have to bear in mind and rule out before starting the patient on medication. Thank you.
Absolute real
That
world
was a
wisdom. These
nice,
last 2 points.
very nice
So
point put across.
If you allow me,
Can
so
we
I
now
would
go
like-
to,
I would-
yeah,
yeah,
sorry.
we'll go to the next
Can
case.
I add something?
Yeah, sorry.
Yeah,
Yes.
Piyush, yeah.
So, in fact, I would like to enforce the point that Sood sir had made. In fact, I had the opportunity to co-treat one of his patients, and in spite of the fact that there was nothing else that was missed during history, but on repeated examination, we found out that the patient was using homeopathic medicines for constipation, and that was leading to a shoot in the IOP, and which was missed for a long time. So, just to enforce his point about repeatedly asking, repeatedly probing. One more thing I would ask the expert panelists to perhaps quickly give us their, kind of for the general ophthalmologist of a protocol or what they would advise them to look for a steroid response when they're using steroids.
How often?
Yes.
How often would you call the patient for intraocular pressure check? And sometimes you can have late responders, sometimes you can have early responders. So what is the protocol that you normally follow for when patients have to be on steroid for some other reason? So Dr. Pooja, if you can just answer the question.
Yeah, so
but what is the protocol?
Quickly in one line. So
Yeah.
So whenever, especially if the intravitreal injection is given, I generally advise the retina people to ask the patient to come every 2 months for 1 year, because we have seen steroid responsiveness up to 6 months after giving the intravitreal. So it is important that we follow them up for at least 1 year after the intravitreal injection. And for topical
You're talking about
medications,
triamcinolone.
yeah, triamcinolone, yeah,
Okay.
tricot, intravitreal tricot.
Triamcinolone. Yeah.
Yeah, yeah. And also for topical medication, I think the same protocol. Every 2 monthly, we need to see if the patient is on long-term topical steroids. That's the protocol I am
Fair.
following.
Okay. So I think we can go to our next speaker. So Dr. Sanket, are you ready with your presentation?
Sanket, share the screen, please.
Sure.
Dr. Sanket will be talking on neovascular glaucoma.
Sanket, wind up in around 8 minutes time, because we need around 12 minutes of discussion.
For discussion. So I'll stop you
Yeah.
at 8 minutes. Sorry, I'll nudge you a little bit.
So my voice is audible and the
Yes.
screen is shared
Yes.
right now.
Screen
Thank
is
you very
shared,
much for this opportunity. 61-year-old male came to the OPD with history of 24 years of diabetes mellitus, and he had very high IOP in the right eye, 38 millimeters of mercury, and 20 millimeters of mercury in the left eye. His disc was around 0.6 average shaped disc, average size disc with a pale appearance, and had dot hemorrhages in all the 4 quadrants along with NVE. I can show you on the pictures that in the right eye, there were florid neovascularization over the iris surface, as well as in the left eye, the new vessels were present only in the pupillary area. So usually the VEGF load, which starts from the ischemic retina from the posterior segment, comes through the anterior to the anterior segment through pupil. So in the first or initial stages of NVG, the new vessels are seen primarily over the pupillary area. And in the angles, in the right eye, where the IOP was really very high, there were new vessels or strands of new vessels were crossing the scleral spur and also were giving rise to synechiae formation in few of the quadrants. So that was the cause of high IOP in the right eye. In the left eye, the IOP was around 20 and the new vessels were seen in the angles in few of the quadrants. So what is the diagnosis? Diagnosis here is the neovascular glaucoma, angle closure stage in the right eye, and early NVG with rubeotic stage in the left eye. In both the eyes, there was cataract, and the main culprit was the proliferative diabetic retinopathy. So how to manage this case? To know that, before we would like to know what are the most common causes of NVG. It's the 2 main causes are diabetes mellitus and central retinal vein occlusion. Which is followed by ocular ischemic syndrome. There are other causes like tumors in the posterior segment, like retinoblastoma. So this is very important. If you are not able to see the fundus because of the hazy cornea or vitreous hemorrhage in between, it is always mandatory to do ultrasonography to find if there is any presence of tumor in the posterior segment or not. Inflammatory diseases can also give rise to NVG. Diabetic retinopathy is the topmost cause which causes NVG, especially PDR. So doing gonioscopy, taking IOP measurements in every visit of this patient is very much important, and timely the anti-VEGF injection application is also important. CRVO and BRVO are also leading cause of NVG, and in these cases also doing OCT and timely intervention, knowing the IOP and gonio structure is very important to avoid a surgical intervention for glaucoma. Ocular ischemic syndrome comprises of 10% of NVG cases, and it is hallmarked by presence of hemorrhages in the mid-periphery, IOP, and new vessels in the angle and over the iris. Doing a carotid Doppler can give what is the exact cause of this ocular ischemic syndrome. FFA, which is not done usually nowadays, can show a delayed filling at 40 seconds. What are the stages of NVG? Pre-glaucoma stage, where it is called as rubeosis iridis, where IOP is very normal, but gonioscopy can show NVA. So giving anti-VEGF injection at this point of time can avoid loss of vision, as well as can save the eye from a surgical intervention. In the second stage, where the angles are open, but the IOP is elevated, new vessels are there in the angle, lots of vessels over the iris, the florid rubeosis is present, as well as aqueous can show presence of cells. Hyphema might be present in few of the cases. In these cases, urgent anti-VEGF injection and starting the patient on anti-glaucoma medication to see the response, and a timely anti-VEGF injection and PRP can help in these patients to avoid any loss of vision. The third stage is the angle closure glaucoma stage, and NVG can progress very fast. That's why timely intervention is very important. Once you reach this stage, assessing the visual potential and accordingly treating the eye is very important. In this stage, the IOP is elevated. The contracture of the fibrovascular membrane can cause flattening of the iris stroma and ectropia and UVA. Progression to this stage can lead to vision loss. So this diagram or flow chart very nicely shows how the treatment for NVG can be given. If IOP is high and useful vision is there, then urgently doing a medical therapy and giving anti-VEGF injection in the presence of retinal ischemia is important. Glaucoma surgery, like doing a trabeculectomy first, followed by tube if required. And if the eye, there is no visual prognosis, then giving symptomatic therapy with the help of cyclodestruction, ESCPC, or cyclophotocoagulation is important. And then I would like to state few differential diagnoses which can mimic neovascular glaucoma. Like in acute angle closure glaucoma stage, there are engorged iris vessels which appear like new vessels, and on gonioscopy of the other eye reveals the condition that this is actually a neovascular glaucoma. Doing a PI and giving anti-glaucoma medication itself can resolve this issue. Also, ruling out any posterior segment pathology is very important. Looking at the retina and fundus to find out any other cause of NVG is required at this stage. A carotid cavernous fistula also can mimic NVG, where dilated vessels can be present over the iris and blood in Schlemm canals.
Sanket, you can summarize in a minute, please, if
Sure.
it's possible.
So in the summary, I would like to tell that slit lamp examination, look for new vessels, undilated gonioscopy is very much important, and finding out the hidden cause or the systemic evaluation is very important to save the other eye or the other organs of the body.
Thank you. Thank you, Sanket. That was a very nice presentation and something which we see in everyday practice. I'll start with the youngest, Pooja.
Yeah.
When you see neovascular glaucoma, okay, so what is the role of PRP? Because Sanket mentioned, he mentioned anti-VEGF, but he's not mentioned PRP. He said PRP in the later stages.
Yeah.
So I know your husband is a retinal surgeon. That's also what I'm asking, that you two must be managing it together. So what is the role of PRP? Do you start PRP at the first stage itself?
Yeah, basically treating the underlying cause is the main treatment. So whenever we are identifying a patient of proliferative diabetic retinopathy, treating the underlying cause is important. So starting with the PRP is the first thing. Second thing, if there are florid neovascularization and associated rise in IOP, then anti-VEGF and medical management of glaucoma should be added. So if it is diabetic retinopathy, PRP. If it is CRVO, also we need to do PRP wherever needed. And if there is an occlusive episode, then we need to understand and treat, take a physician's opinion if we want to start the patient on ecosprin or anything like that for a carotid, do a carotid Doppler also to find out what is the cause for ischemia, retinal ischemia. Yeah.
So the point which I wanted to bring out is that when you see NVI, look for the underlying cause, and PRP does remain the
basic
mainstay of treatment across the across the presentation. Dr. Piyush, you are also a retinal surgeon, so please feel free to, what is your role on,
I
do
think
you agree that PRP should be done?
at this point, I think we should slightly interject and say that PRP in these scenarios has to be a well done PRP. Why I'm saying well done
Right.
is that there are certain things that qualify for a good PRP in NVGs and CRVOs. That is, the burn width should be less. There should be less burn width apart, covering the entire fundus, making sure that the entire neovascular stimulus goes away. Because few shots here and there are going to just worsen the situation and give a false sense of security. It has to be done very, very well. That is very important.
Dr. Kavita?
Yeah, I strongly
Now,
agree with you. Even like I was wondering when PRP was not mentioned at the first stage, even if it is like a single vessel in the angle, even without a neovascularization of the iris, we have to just make sure like we go ahead with the definitive treatment when we suspect neovascular glaucoma, which is a pan-retinal photocoagulation. So probably this anti-VEGF will help us to reduce that VEGF load, and also it will take care of the inflammatory part also, and it will help in the faster resolution of these new vessels. I strongly agree with that. Yeah.
Very true. So we've had PRP for a very long time, but I agree with what Sachin said, is that it has to be a well done PRP. But now, in addition, we also have in an armamentarium anti-VEGF, very good anti-VEGFs, which we should not shy away from using in such situations. So I think that about we can use a combination of both in such situations. Yes.
So, Dr. Sood, we have seen many times people, when they are treating neovascular glaucoma, they don't start PG analogs for the fear of, inflammation. So just can you tell us in brief about the medical management when a patient with neovascular glaucoma presents? Do you still go the step-by-step approach? Do you still use prostaglandin analogs? So can you just focus on what we should do for medical management?
So, Dr. Preeti, I will answer that question. I'll also answer that question on PRP, that despite be doing so much PRP and despite giving so many anti-VEGFs, neovascular glaucoma is only increasing. So where's the problem? Something's not working right. I will leave that for a thought process to say that hypoxic areas need to become anoxic, and therefore good PRP needs to be done. That's where we are probably missing out in the numbers that we are treating, that we are not doing adequate PRP. The reason why people are hesitant to give prostaglandin analogs in neovascular glaucoma is because these blood vessels are not like normal blood vessels. Their structure of the wall tends to leak and therefore produce more inflammation. And prostaglandin analogs are actually mediators of inflammation. So what we are likely to do is aggravate the inflammatory part. Second thing to keep in mind is diabetics also have inflammatory vessels. So when you see actually a patient who has a neovascular glaucoma, your treatment should include some low dose steroids for that patient, because some of these blood vessels will resolve as a part of that inflammatory process. And if I was to add and summarize this and say, the neovascular glaucoma we are talking about will be a manifest neovascular glaucoma. Then we'll have a stage prior to that where just the NVI have formed. And then we'll have these so-called venous occlusions in diabetics who have no diabetic retinopathy also. And still they have followed up with us. So those are the ones we actually need to start focusing on. It's a pity that fluorescein angiography is not being done. Because if you have a patient who is a diabetic with no retinopathy, fluorescein was one of the earlier ways of picking up the leak of fluorescein into the vitreous cavity, saying this is the patient who has the possibility to develop NVI. And that's where we needed to be very aggressive in our treatment. My only other suggestion is every time you see a diabetic, even if he or she doesn't have NVI, please make a note that no NVI. It's very good for the future as you document these patients over time.
Yeah, wonderful point. Wonderful point. I think we are also finishing the time of this case. So just one passing question to all the experts. When do a trab and when do a tube in these cases?
So
Quickly.
we usually, I think always, like as we all know, glaucoma is going to be a lifelong process. A neovascular glaucoma is one of the intractable type of glaucomas. We have to always bear in mind. So the first opportunity is definitely, usually we say like whatever you are best at. either a trab or a tube you can do. But we do also have to think for the patient, like once we do a GDD, doing a trab is not at all a possibility. If the eye is quiet, if the angles are well open, and if the inflammation is controlled, definitely trab is also an option. But usually when I get to see the patients in advanced stages with 360-degree peripheral anterior synechial iris getting pulled up, then in those sort of intractable glaucomas, usually we consider a glaucoma drainage device. Again, there is a lot of debate always goes on between whether to use a non-valved device or a valved device. So we have to bear in mind the chances of hypotony, which is possible with non-valved glaucoma drainage devices like RD. And these eyes are more prone for hypotony episodes. In case if we use non-valve devices, always we have to make sure to use the rib card in these patients and reassess and decide on the removal of the rib card at a later stage. And one more thing, as far as like neovascular glaucoma is concerned, since I work in an institute, usually when we see such patients, if the cornea is clear, we will request our retina colleagues to consider doing the PRP on the same sitting without even giving an appointment. Sometimes we give the appointment in a couple of days. By the time they come back, the cornea becomes edematous. Then, we lose the chance of doing PRP. That's one thing which we should bear in mind.
Yeah, that I think is a very, very important point.
Fabulous point. Yeah.
So the moment
Pooja,
you see
tubes
a
or
clear
trab?
media,
Sorry.
Yeah, I prefer doing trabs. Yeah, because
Trab.
it is more cost effective. That's my first say. And I can repeat if I want. I can do one more trab that has failed. I can do needling. But if you do a tube, there's always a lot of inflammatory response. So if it fails, multiple needling for a tube is very uncomfortable, I feel. I prefer trabs, and trabs have done well in my hand.
Yes.
For even for the neovascular glaucoma.
Yes. Yeah. Dr. Sood, tubes or trabs?
Trab, mitomycin with releasable suture.
Yeah. So I am on team trab too. And if required only, then team the GDD. So Sachin, can we go on to the next topic? Is that okay?
yes, absolutely.
So Sachin, as the next slide comes in, I'll just add and say that, in the early 1900s, it was said that if a patient develops neovascular glaucoma, think in terms of enucleation. And now if you see a large number of these neovascular glaucomas, if they are treated promptly, and in fact, most of them actually do well, or even though it may require multiple surgeries and medication thereafter. So I think our understanding of the disease process has got better. We tend to still get frustrated at times, but we are not thinking in terms of any enucleation.
Yeah, but so I mean, that's a very, very
Aniket.
important point. We can save almost all neovascular eyes nowadays. And the worst case scenario, in fact, in most of the treated eyes, well-treated eyes, is a painless blind eye. So I think that's quite a big achievement considering what they present with if they are not treated well.
Absolutely. I think an enucleation is psychologically depressing. And having no vision but the globe intact is a better option than having an enucleation.
I think Dr. Preeti, we can go to the next case.
Dr. Aniket, if you can just share your screen, please. He's going to, Dr. Aniket, he's a glaucoma specialist from Nanded, and he is going to talk to us on pseudoexfoliation glaucoma. So I think go to the first slide.
Yeah. Good evening all. We will start with the presentation. So it is pseudoexfoliation glaucoma. It is the most common identifiable cause for open angle glaucoma worldwide. It is also a systemic disorder with important eye manifestation and development of open and closed angle glaucoma with cataract and zonular instability. Then it is most common in older age group, mainly 60s and 70s. It can be a unilateral and bilateral asymmetric presentation. There is a no sex predilection. Geographic distribution patterns are there. About 40% of the patients with pseudoexfoliation will develop glaucoma. About 20 to 25% of open angle glaucoma patients worldwide have pseudoexfoliation syndrome also. So going with the pathogenesis, it is inherited microfibrillopathy. Polymorphism in the coding region of LOXL1 gene is there. So mainly oxidative stress, ischemia or hypoxia or low-grade inflammation will may lead to the pseudoexfoliation syndrome. So hypoxia, ultraviolet exposure, sun-near weather, then high altitude, low ambient temperature, decreased level of antioxidants, higher folate intake, and increased coffee consumption also can lead to a pseudoexfoliation. There are also systemic association with the pseudoexfoliation syndrome that are vascular, cerebrovascular stroke and transient ischemic attacks can be seen, homocystinuria. Then Alzheimer's like dementia, sensory neural hearing loss can be there. Then what are the clinical features in this one? There are some corneal changes. We can see the flakes of exfoliating material and pigment accumulation in the corneal endothelium. There are changes in the endothelial cell size, shape, and decrease in the cell density. Corneal endotheliopathy in pseudoexfoliation, there are appearance of guttae which are different than the fugues. These guttae are diffuse in thickening and atypical there. In fugues, there are smaller size of guttae there. Then exfoliative material on the anterior lens capsule, we can see there are three distinct zones are there. A central translucent disc is there, clear zone is there in and in peripheral there is a granular zone with radial striations. There are some stages we can see that first is the preclinical stage, then suspected exfoliation syndrome is there, then mini exfoliation syndrome will start with the superior nasal quadrant, and then classical exfoliation syndrome can be there. Exfoliative material first earliest detected in the ciliary processes and zonules. There are involvement of zonules can lead to the phacodonesis and lens subluxation. And the proteolytic enzymes in the exfoliative material can lead to a lens instability. So we have to keep in mind while doing the cataract surgery in these cases also. This image shows the ultrasonographic biomicroscopy used in exfoliation syndrome. There is a patchy granular appearance over the zonules. So we can see in the UBM. There are some iris changes. Typically, iris transillumination or moth-eaten appearance we can see. If fluorescein angiography, if you do, there is a hyperperfusion, peripheral leakages are there, and some neovascularization we can see. Gonioscopic finding, typically we can see the sampholysis pigment accumulation along the Schwalbe's line. Usually AC is deep. There are 9 to 18% chance of occludable angles in these cases also, and angle closures in 14%. So other slit lamp findings, we can see exfoliative material in phakics also, and in pseudophakics after Nd:YAG capsulotomy. So exfoliative material can get deposited in other extra bulbar sites also, that is conjunctiva, orbital septa, extraocular muscles, vortex veins, posterior ciliary arteries, and central vessels. So pseudoexfoliation glaucoma, it is a more aggressive and poorer prognosis than the normal tension and chronic open angle glaucoma. There is a high IOP and more increased diurnal fluctuation than the others. So there is a greater vulnerability to the optic nerve for the damage. In this graph, we can see there is a more progression of the exfoliative glaucoma than as compared to the other glaucoma. It is over the 6 years graph. So what are the mechanism? LOX L1 gene predisposed to the glaucoma. There is increased production of the exfoliative material and is passive deposition and the endothelial cell damage of the trabecular mesh line. Then glaucomatous neuroretinal rim damage is more diffuse, may present with the acute rise in IOP that mimics the angle closure glaucoma. In this case, there is a corneal edema. IOP may be higher than 50 millimeters of mercury. So mechanism of angle closure glaucoma, zonular weakness can cause the anterior movement of the lens pupillary block, which can cause the angle closure glaucoma. Relative anterior microphthalmos, people with pseudoexfoliation who are predisposed to the angle closure have smaller anterior segment but normal axial length, shallower central AC depth, horizontal corneal diameter less than 11 millimeter, greater than average lens thickness. So what are the differential diagnosis for this one? It is first is the capsular delamination, which is called as a true exfoliation also. Then primary amyloidosis, there is a white flaky material over the anterior capsular lens, eyes, and anterior chamber angle. Pigment dispersion, which can mimic with the pseudoexfoliation, that is pigment dispersion syndrome and pigmentary glaucoma. Melanosis, melanomas are there. Anterior uveitis cases also there. Chronic open angle glaucoma. Unusually heavy pigmentation in otherwise normal eyes. So what is the management? Target IOP is said to be low and close follow-up should be there. Prostaglandin analogs are the best response. Combination of prostaglandin analogs and timolol works better. We can use a pilocarpine 2% at bedtime also. So more IOP reduction and improved outflow facility and decreased trabecular measured pigmentation. If occludable angles are there, we can use a laser peripheral iridotomy. Open angles, SLT works better. Microinvasive glaucoma surgery, slightly elevated IOP and mild to moderate glaucomatous damage, we can do that also. Or we can go for a filtering surgery in high IOP and advanced glaucomatous damage. Cataract surgery we can do may alone decrease the IOP, but difficulties are there.
We have to conclude, Aniket. Conclude in the last
Yes,
few
sir.
lines,
Last
please.
line only. Yes, sir. Large capsule orexis we should do during hydrodissection. Tap on the center of the nucleus to decompress the fluid. There will be a zonular weakness, so we can do a capsular tension ring and segments we can use. Small people mechanically we can dilate or maintain the pupillary dilatation. Thank you all.
Okay.
That was a nice
yeah.
talk, Aniket. Before we go on to discussion, Dr. Lahane has joined us, and we can just ask him to address us for a minute.
We have
Dr. Lahane,
with the Sood sir's permission, sir, we have our MOS patron, Dr. Lahane sir, who's there. Sir, तुम्ही mute आहात, sir.
Thank you. Thanks.
Sir, good evening.
Good evening.
Good
Good
evening,
evening.
sir.
Good evening, everybody. I was just listening about the pseudoexfoliation glaucoma, and I think what he was saying is very true. And yeah, I really appreciate you all for the glaucoma week that all over India. I think you did so much of the, can say, in the people and everywhere. So I am very happy for that. And see, glaucoma as it is, can say the disease, the silent killer. So it is very much required that we should get examined in the indicated people should get examined and get treated earlier. So you are doing very good work. I appreciate the Glaucoma Society. I am also a member from so many years in Glaucoma Society. So my best wishes. And only one thing is that I am contesting for the post of Vice President of India Ophthalmological Society. 24th March to 31st of March in the morning 6 a.m. there will be online voting. So requesting your support for that, and thank you very much for permitting me to join with. Thank you very much.
Thank you so much, sir. Thank you.
Thank you so much. So, shall we?
With your permission, Dr. Piyush, we can go ahead with the discussion.
Yes.
Yeah.
Yeah. So, Dr. Sood, would you treat pseudoexfoliation glaucoma a little differently from what you would treat a primary open angle glaucoma?
So for me, pseudoexfoliation is an important risk factor. And it's also, if its presence is easy to diagnose from a glaucoma perspective, so I would be very aggressive in treating a patient who has pseudoexfoliation as compared to another patient with open angle glaucoma who doesn't have pseudoexfoliation.
Okay. Any change, any difference in the medical management, the drugs you would use, or you would still go the same step-by-step approach as we use, and prostaglandins first? That's how we do it in primary open angle glaucoma.
Yes,
is there
but
any difference?
I would not be hesitant to add more drops and try slightly aim for a lower target pressure. And depending on the patient's age group, there would perhaps be no hesitation in trying to add a little pilocarpine.
Right.
I think these are very, very important points, considering the kind of audience we have. A lot of them treat rural population, and the incidence of pseudoexfoliation is very high, especially in central part of India. So I think what sir has said, very, very pertinent points are that he will not treat pseudoexfoliation open angle glaucoma in the same way as primary open angle glaucoma. I think these are words of wisdom gained through a lot of experience. And these eyes are certainly notorious in terms of their pressure spikes, as pointed out by Aniket in his presentation, as well as progression, which is much faster, maybe because of the nature of pseudoexfoliation affecting the entire ocular, entire gamut of ocular structures. So, Dr. Kavita and Dr. Pooja, would you like to come in with some additional pointers?
Yeah, I think medical management is a bit more difficult with the pseudoexfoliation. So we need a more closer follow-up for these patients as compared to POG, and maybe at earliest consider surgical option wherever there is associated cataract or the glaucoma is more aggressive.
Okay.
Yeah.
Dr. Kavita?
Yeah, I do agree with all of you. Definitely, we need to be more aggressive in treating these eyes. And one more point, like which we have to remember is whenever there is a highly asymmetry in the presentation. So most of the time, these can be like one of the important causes of like advanced glaucoma presenting as like uniocular in one eye. So this is one of the causes which we have to rule out carefully. If we look for the pseudo exfoliation material, we'll be able to see. And not only glaucoma, and sometimes these patients can present with a pseudo exfoliation syndrome even without disc changes with very high pressures. Then also it is like unlike other ocular hypertensives, like these eyes are more they tend to progress. We need to have that in mind and treat these patients little more aggressively than we address a normal patient with primary open angle glaucoma.
I think wonderful point about that uniocular presentation. I think it's a very, very important point. I think we should keep in mind.
So a take home for the comprehensive ophthalmologist is that it is not the same as primary open angle glaucoma. It is more aggressive. So you can be more aggressive in your management. Second is that sometimes they present very late. And that's again when you may need to resort to surgery earlier. And keep in mind the other eye, because it's maybe seemingly like a unilateral glaucoma, but look very carefully at the other eye. So summing them up, what is the, if a person has pseudoexfoliation, how often, but has no high pressure, how often would you follow this patient up? Not all pseudoexfoliations become glaucoma, but there is a risk factor. So how often would you follow up a patient with pseudoexfoliation? So Dr. Sood, if you can start the discussion, please.
Every other parameter being normal, 4 to 6 months. More towards 6 months.
About 6 months. Yeah. All right. Pooja, anything else you have to add?
Maybe I'll explain to the patient the reason why we want to see him more frequently, because there is a risk of development of glaucoma. And then accordingly 6 monthly or 1 yearly. Yeah, if there is no sign of glaucoma at present.
Okay. Now suppose, Dr. Kavita, if we have to operate this patient, not responding to medical treatment, is the trabeculectomy which you're doing, is it going to be different from what you would do in a primary open angle glaucoma?
So practically considering the surgical management, the way you do the surgery will be the same, and you have to bear in mind while doing peripheral iridectomy, the possible weak zonules associated in this eyes. There can be sometimes like a zonular dehiscence and vitreous prolapse, which can block your ostium. So we have to be prepared for that, and we need to discuss the pros and cons of the surgery with the patient. And frequently we see these eyes, it's making the bleb survive in this eyes like more challenging than we do a routine trap in primary open angle glaucoma eyes, because these eyes tend to have like a thinner conjunctiva. So initial hypotony and then like high chances of failure in these eyes. So we have to keep them under the periodical review so that we can do the necessary intervention in the form of the bleb massage or giving the antimetabolite injections or doing the suturolysis. They need like maybe like more frequent follow-ups and interventions, as these eyes, they are more prone for high risk of trabeculectomy failure.
So can I add?
Yes,
can I add?
Please,
exactly.
go ahead.
If you're planning to give anesthesia to these patients before surgery, make sure that the eye is the super pinky or something, or compression is done very carefully, because the zonules will be weak. So you may have a surprise with the lens going back sometimes.
We may have a cataract surgery along with it.
I thought super pinky was history. That's what
I don't know. I don't do cataract, so I don't know. But I have a question here. See, we are all talking about pseudoexfoliation from a glaucoma perspective. Let me ask, if this patient with pseudoexfoliation, no rise in intraocular pressure, no disc changes, has to be taken up for a cataract surgery, will you do only a cataract surgery, or will you combine a glaucoma surgery with that?
I'll combine a glaucoma surgery, because if the pressures are high and cataract is there, we might as well lower the IOP.
Let me
Otherwise,
rephrase this question and say that the pressures are normal. There's a pseudoexfoliation and a cataract which is operable. Will you add a glaucoma surgery?
no.
No.
Pressures
No.
are normal, no.
Pressures are normal,
No.
no glaucoma, no
Only
Family
distinct.
history of glaucoma. See, the reason why I'm asking you is that we all have acknowledged just now that pseudoexfoliation is very important risk factor, and eyes with pseudoexfoliation progress faster. So I'm asking in that context that if suppose everything is normal, this person has come for a routine eye checkup, has pseudoexfoliation and a cataract which needs to be operated, but has a family history of glaucoma.
So we need to do the cataract surgery and discuss the risk of and do follow them up with glaucoma.
Agree.
And no glaucoma surgery unless until the patient has glaucoma for sure.
For cataract
True.
surgery, I think we should take extra care for the endothelium also, because sometimes they are associated with very poor cornea. So we have to be very careful while operating hard cataracts or this difficult cases.
So in
Role
my
of MIGS in pseudoexfoliation glaucoma. Each of you, your views on that. Dr. Kavita, Dr. Pooja, Dr. Sood. Let's start with Dr. Kavita.
Yeah, for one additional question for Dr. Kavita, because the Arvind Eye Care system does a lot of SLT. The role of SLT in steroid-induced and pseudoexfoliation as a passing comment.
Actually, we don't do a lot of SLT at Arvind Eye Care system, but definitely it has a role to play. So all our branches didn't have access to SLT. We recently had one, but considering the pathology in the outflow, conventional outflow process, definitely theoretically, and also there is evidence to say that especially in conditions like steroid-induced glaucoma, SLT has a role to play. Mix, of course, yes, when the disc damage is not advanced and when the patient has mild to moderate glaucoma and the patient has a cataract as well, we do a combined mix procedure along with the cataract surgery.
Which is your favored mixed procedure?
Which mix? Yeah. Which one? Which mix?
Kinetogoniotomy and KDBs, which is like 180 degree.
Okay. Tanito and KDB. So something like a hemi-GAT. But you're not in favor of doing a full 360 GAT nowadays, or how is it?
Like it is a procedure of choice, but still, not having the evidence for treating 360 degree, and we don't know the long-term outcomes. So we do prefer to do 180 degree rather than considering a 360 degree.
And between the Tanito and the KDB, you find similar results, or how is it? Because the cost is very different. I mean, so that's why for the viewers,
very different. Cost is very different. That's why we prefer Tanito, which is a reusable thing. Correct. And it is less traumatic also when compared to that of the band, which is also a cutting procedure. Outcome wise, definitely yes, almost all work the same.
The Tanito and the KDB almost work the same in your hand.
Yes, yes.
Okay. Yeah. Thank you.
Yeah. Pooja, what was your opinion on MIGS? And
I have done mostly phaco GAT, so it has done well in pseudoexfoliation. Really well, surprisingly well. In mild to moderate, of course. Only mild to moderate glaucoma with pseudoexfoliation, phaco GAT has done well. I have a follow of 1.5 years and they're doing well. So,
all right.
Yeah.
Dr. Sood, your opinion on that?
So, it will depend on our practice profile. I rarely see patients who have early glaucoma coming for surgery. Most of them are actually advanced glaucomas, split fixations, uncontrolled glaucomas, or repeat surgeries. So I think they are not candidates for MIGS in any way. Okay. So I would opt for a trabeculectomy, mitomycin with a releasable suture.
All right, along with cataract surgery. If
so
you're doing
I don't do
cataract
surgery. So if that is the situation, then I will refer them to somebody who does both together, because I'm into a pure glaucoma practice.
Sure. Fair enough. So it is 9 o'clock, and people must be going for their dinners, wanting to have dinners. So Dr. Piyush, if you can give the vote of thanks, please. Any other questions, Sachin? Sachin, you're mute.
get your last word because I was just on some urgent call. Yeah.
Would you have a last closing question or comment?
Any questions? Last question.
Passing
Yeah,
comment.
no, I think pretty much we've addressed all these three very important issues. I thank all our expert panelists for giving us all the practical tips and all our presenters for getting excellent cases for discussion. So I think all the points that needed to be conveyed, we have, I think, pretty much ticked all the boxes. So any other thing, any expert wants to mention, or Dr. Preeti from your side before we conclude?
No, I think we can have one full session for pseudoexfoliation glaucoma, one full session
Full
for
session.
neovascular glaucoma, and it will still be less, you know. But yes, the
Yeah.
salient points have come across. So I take the opportunity, Dr. Kavita, Dr. Sood, Dr. Pooja, for coming here, and Sarika, Aniket, and Sanket. Wonderful presentations. Dr. Piyush, you can just
I
take
think
over.
you've already mentioned everything. It was a very great learning experience for me as well, and especially having Sood sir around over here was absolutely marvelous. Thank you so much again from MOS, from Scientific Committee, to Sood sir, Pooja madam, and Kavita ma'am. Thank you so much to all the speakers, dear Sanket, Dr. Aniket, Dr. Sarika, and of course, Dr. Preeti and Dr. Sachin for carrying the session so well. Thank you so much. And perhaps you can maybe do an entire session on pseudoexfoliation.
Sure.
So
Okay.
Each of
thank you very
diseases,
much
yeah.
for being here.
Okay.
Good night.
Good night. Good night,
Thank you
everyone.
very much,
Good night.
everyone.
Thank
Good
you so
night,
much.
everybody.
Good night.